Welcome to Between Two Ovaries, your go-to for all things women's health.
A lot of people just say like, oh, my vagina.
Yeah.
And
Yes.
that's
all
not,
of the above.
That's not your vagina.
No.
Well, it is.
We're here to cut through the confusion, bust some myths, and give you the facts straight from the experts.
You cannot still believe the amount of people that come to a gynecology clinic saying that they don't look right down there and they need something doing about it.
We're keeping it real, bringing you honest conversations about topics that matter to you.
Everything goes back to the menstrual cycle. Yes, it's a low-risk procedure, but it's not a no-risk procedure.
From periods to menopause and everything in between, we've got you covered.
So whether you're here to learn, laugh, or just listen, you are in the right place.
As soon as I said it,
So, welcome to this episode where we're going to do a bit of a season 1 recap. We don't have a fun name at the minute. We'll try and find one. But we've got 25 whole episodes out there.
25!
25! Mental!
Well, no, season 1 was
year.
25. We've now got another 7 of season 2.
This is true. So we've
Wow.
got...
This
But
is
as
like,
of
a
now,
lot.
season 1 is 25 episodes.
yeah,
Yeah.
25 episodes is season 1, so we're going to
An
do
entire
a-
year
gonna
of our
recap these
lives.
25.
Yeah.
Which is crazy.
mental.
But it's been great, hasn't it?
All
Yeah,
devoted to you guys.
and all things women's health. So what we thought it would be nice to do is a little recap. So we'll spend a few minutes per episode. Just, give us what you thought your main points were. Yeah, all 25. So the first one, number 1, myths about the Marina coil. That's where we chose to start.
I know, rogue. Absolutely rogue.
When we think
Legendary, I
about
would say.
it, we went back to basics like way after that.
Oh yeah, that's like number 6.
Yeah, I get it, but this was where the passion project came from.
Yeah,
so
this
it
started
was
it all.
about the myths about the Mirena coil because I was very annoyed that people kept coming to clinic and saying that they didn't want a coil because their friend's auntie's sister's dog had one and it came out of their
Yeah.
nose, and I was like, not a thing. And we were like, we need to get good information out there. And then this is where myths about the Mirena coil came from.
It was an important one to get out.
Yeah.
So we all know now that the Marina is one of the hormonal coils.
Yeah.
It's used for contraception. It's also really great because you can use it for heavy and or painful periods. And in a lot of women who have a coil, they will not have any periods after it has settled in and started to
We
work.
love to see it.
So yeah, if you don't want a period, you don't have to have one. Have a Marina coil would be
Yeah.
what I would say.
I feel like we have to caveat with this with we don't get paid by Mirena.
Not yet.
we are
hope
not
to.
sponsored.
No,
We
not
do
yet.
think it's a good idea. It's not great for everybody. Some people do have issues with the coil. There are other versions of a progesterone coil. We're happy with any of them.
Yeah.
They thin out the lining of the womb and cause you to have either lighter periods or no periods at all. We use them for, as you've said, heavy painful periods, endometriosis, HRT. We use them part of it as
Yeah,
HRT,
yeah.
progesterone
Therapy.
or arm of HRT. So they have actually revolutionised gynecology.
They have.
They have.
They're going to do us out of a job eventually.
Yeah, no, in a sense, like when you look at the amount of hysterectomies that were done before and after the introduction of a progesterone coil, the difference is massive.
Yeah.
So they have totally revolutionised gynecology.
Yeah. And so the best myth we had was it's perfect for everyone.
Yeah, no, it's not.
no.
It's perfect for a lot of people.
Yeah.
Some people can't have one. If you have a uterine abnormality, so if your womb is a different shape, you might not be able to have one. You might still. But also just from personal preference, some people don't want to have the procedure of having it put in because it can be painful. But for many people, the kind of benefit of not having any bleeding.
So, probably the most frequently asked question is, how likely is it that my Marina coil will go missing inside my body?
Really unlikely. Like,
Great.
genuinely, worked at the women
Glad
since
to hear it.
2010 and I've seen it like twice or something.
Yeah.
Okay.
Really uncommon to happen.
It's more common that it might just be in your womb but not quite in the right place.
We are going to cut you lot off at some point.
Okay, are we too long?
Yeah.
Okay,
right,
we'll just
come on,
move
let's
on.
move
Go
on.
on
Yeah,
now.
we got it.
So our next episode was how to get pregnant, the ins and outs.
Okay, so how to get pregnant, and this was because although people think that they know how to get pregnant, as in have unprotected sex, you spend a lot of your life trying not to get pregnant, and then when you come to want to be pregnant, people actually don't get this kind of
Easier said than
idea.
done.
Yeah.
And I think the key message as well is that it can be normal for it to take up to 2 years. There might not be a problem, but it feels like there's a problem when you start trying, you have sex and then you have a period and you're like, oh, what? There must be a
Why did
problem.
that not
Why did I
work?
not get pregnant? So we wanted to explain the ins and outs of how
Yeah,
to
we
get
totally
pregnant.
talk about like the cycle, and you have 2 different stages. You have an ovulation in the middle, and the ovulation moves you from your first part to your second part of your cycle. And when you kind of do that pregnancy test, if you have a missed period, you would already be 4 weeks pregnant, which is mind blowing.
Yeah, still don't get that maths, I can't lie. Still struggles.
So it was just to kind of hammer it home that it's not like the movies. Lots of people take quite a long time to get pregnant, and that
Yeah.
can be totally normal.
Yeah.
Amazing. So our best myth there was you can't get pregnant on your period.
Yeah, false. You can get pregnant on your period. It's unlikely, but if you have sex, sperm can live for up to 7 days in the reproductive tract, and you might ovulate a little bit early, so they could meet when you don't want them to. So it's not completely safe. You should still be using protection if you don't want to get pregnant.
Yeah.
Love.
And does taking hormonal contraception affect fertility or extend your reproductive window was our frequently asked question.
Okay, so taking
No.
hormonal contraception, she's like, no, it's just
No,
a no,
I know.
guys.
Sure.
Definitely just a no. Taking hormonal contraception doesn't affect your fertility. If you're on something like the combined pill, it can take a while for your periods to come back. That can be normal, but if they've not come back by 6 months, please do see somebody. And it doesn't extend your reproductive window by being on contraception. You don't store up all your eggs. Unfortunately, your eggs still undergo atresia, and you're just losing them year on year.
Yeah.
I feel like we've stressed you out. You are like, right, we're getting through this.
It's like,
We're like,
so quick fire.
Episode 3 is endometriosis essentials.
So
What are the
Okay.
essentials?
this is a condition where the endometrium, which is the inner lining of the womb, grows abnormally outside of the womb, most often in the pelvis, but it can grow anywhere in the body, and it can cause symptoms like heavy, painful periods, chronic pelvic pain, and can cause subfertility as well.
So it's an estrogen dependent condition. So when we're trying to give treatments for this, we're trying to kind of take your cycle down so that you're not having periods, you're not bleeding. So the first line treatments are all hormonal based treatments.
And big myth, endometriosis only affects women in their 30s or older.
No.
No, it can
Totally.
affect women of any age, most likely premenopausal women, but you can have endometriosis and then go through the menopause and still have problems.
Yep.
But yeah, it can affect women of any age, even young girls, teenagers.
And I think it's that thing where people are always like, if you've got endometriosis, then you will have chronic pelvic pain and you won't be able to do X, Y, and Z in your life. But actually, you do see some people that will have very severe endometriosis and they won't know that they've got endometriosis, and they only realise it when they come to wanting a pregnancy or a surgery, like even like a sterilisation, and you find it at a
Sometimes on other
sterilisation
things,
sometimes. So just because you have endometriosis, it doesn't mean that you're going to follow everybody else. I think they have a myriad of symptoms and you could fall into various different camps.
And our FAQ was, does surgery cure endometriosis?
No.
Surgery has a part to play in treating endometriosis, but unfortunately there isn't a cure for endometriosis. Surgery might help you, but it might not be the right thing for you as well.
A lot of the studies would say that if you have a surgery, you could get better for a short time and then it would kind of come back, or it could get worse again. So surgery, it would be a lot of the times in combination with hormonal treatments to try and kind of die down the kind of condition.
Got it.
Great.
Episode 4 was the HRT lowdown, what every woman needs to know.
So we did this because this was, I feel
This
like
is
this
another
was
one that you
a
were like, we
well
need
on
to
the
do
back
this
of the clinic.
episode.
I know. Because I felt like loads of people were on HRT because it was the thing to do, because well, it's still the thing to do, because we've seen that HRT makes your life better, because Davina, look at her, I mean, she does look amazing.
Yeah.
It does. It's probably not just HRT, but it's not to look like that.
Yeah, but it was kind of that people are going on HRT, but they're not understanding the different bits of HRT. So there are estrogen and progesterone. If you have a womb, you need to be on progesterone, because progesterone protects the lining of your womb. Your estrogen stops you from having any symptoms, or helps with the symptoms of menopause, like hot flushes, vaginal dryness, night sweats, all this kind of stuff. But HRT has only been proven to help with a small amount of symptoms, so it's not going to be life-changing. And I think it was just kind of getting that across, that HRT can be very helpful, not for all, and if you're going to be on it, you need to be on both hormones, unless you've had a hysterectomy whereby you've had your womb removed.
Okay. Our biggest myth there was that testosterone is an essential part of HRT, but it causes aggression and it'll bring your sex drive back.
So it's not an essential part of HRT. It can help some women who have low libido, but even women who definitely have low libido, only 1 in 10 of them will be helped with testosterone, so it's not great for everyone.
Yeah.
It can have side effects. I think most commonly the side effects are hair growth, because it's a cream that you tend to put on your skin. But testosterone can be linked with aggression, so we can't say that it doesn't cause aggression. And if you're taking a lot more of it than you should, then it could cause
Yeah,
all
you
sorts
can
of
have
side
it
effects.
like acne, male pattern baldness. You can get lots of things from testosterone.
And aggression's not the easiest thing to measure either.
No.
Frequently asked question, how long can I take HRT for?
So you can take it indefinitely, but you should always be on the lowest dose that's working for you. And if you find that actually it's not helping with the symptoms, then why are you on it?
Yeah.
And if you, it would be frowned upon to kind of continue, you would be reviewed at various different times and being kind of warned about the risks of being on HRT. But if you feel like, if you've had an educated decision about the risk v benefits and you think that the benefits outweigh the risks, outweigh the risks, then people can stay on it, but you should be on the lowest dose that's effective for you.
Great. So now up to number 5. So we're almost a fifth of the way through what we've done. Down there care. Vulval and vaginal wellness. I had to make sure I said that right.
This was one of my favourites.
It really was your baby.
featured
My favourite
the
name.
spread.
Yeah, that was so
Such a
ridiculous.
good giggle.
Which was about the wall of vaginas, and it
There's a
was
spread of
the
different
spread of different appearances that will be on the wall of vaginas, which was great. But yeah, so this was probably one of the first ones we should have done, because it was a bit more back to basics.
Yeah.
What the vagina is, what the vulva is, because as we all know now, the vulva is everything on the outside, and the vagina is just the tube that connects the outside to the neck of the womb. The vagina is a blind ending tube. You will not lose anything. You might not be able to retrieve something from your vagina, but it won't get lost in your body from being in your vagina. And the key message really from this was you need to not use soap on your vulva. Don't douche, don't put water and soap in your vagina. It is self-cleaning. It will cause problems if you change the pH by bringing in soap.
Yeah.
So
Leave
just
it
use
alone.
water. Yeah.
Leave it
Let her
alone.
do her own
It's
thing.
self-cleaning.
Let her clean herself.
We left this episode with an unsolved myth.
Okay.
And we didn't know
Oh, yes.
about pineapple or other exotic fruits changing the scent of the vagina.
So I did a bit of late night reading about this. And
Google.
there is no scientific evidence that eating fruit will change the vulval vaginal secretion taste or smell. There's anecdotal evidence from partners who've decided to try eating a bit of pineapple and see if things taste different, but there's no scientific evidence. There is scientific evidence that the pH, your hygiene, and lactobacillus, which is the
Have you done a systematic review on
no, but someone has. That will change the odour and the smell and the taste of what is called on TikTok coochie juice.
Oh,
But
sure
no,
about
unfortunately,
this.
eating a bit of fruit will not change.
TikTok now?
No, I'm not. But I found this somewhere else. So no, it is a myth, unfortunately.
Okay, and then our FAQ for this one, does discharge change across the cycle, or does it mean an infection?
No, discharge changes massively across the cycle, and this is because your body is doing what it should be doing.
We love.
So it's especially mid-cycle, you have very thin, they call it egg white discharge, and this is to help the transport of sperm, because this is the time when you should be getting pregnant if you were going to get pregnant, and then it will get thicker towards the end of your cycle because you don't need to let sperm in at that time. So it will change throughout your cycle, and that is totally normal. Having vaginal discharge is normal, guys. Normal.
Lovely stuff. And then episode 6 was potentially something we maybe should have started with.
Definitely.
Okay.
But we have back to basics inside the female reproductive tract.
Yeah, I feel like episode 6 was fine for this.
We got it in there somewhere, it was fine.
You can listen to it out of
Call it
sync.
back to basics if we did it at the start.
True.
So this was to go through the anatomy so that people understood the blind ended vagina, and then up to the cervix, the womb, which is small, kind of like a fist kind of size. Because I think people are always like, oh, it's my womb that's causing the swelling in my lower tummy, and it's not, because your womb is really very small and tucked behind your pelvic bone. And then you've got your fallopian tubes with these finger leg projections.
We love to watch.
Yeah, and then when you ovulate from the ovary, the egg is wafted afterwards into the tube and
There's a lot
down
of hand
to meet.
actions in this episode.
down to meet the sperm if it was a time that you were going to try and get pregnant. So it was just going through that, and we also actually went through all the hormonal control of the cycle.
Yeah.
So you got the HPO axis, and you've got all your hormones doing different things at different times of the cycles. So I think it is back to basics, but it's essential knowledge.
Yeah,
quite a
essential
lot.
knowledge
Yeah.
to understand your periods and all the things that could go wrong.
Yeah.
Definitely.
And our myth there was quite common, actually. People think ovaries are sort of free floating in the abdomen, just doing whatever they fancy.
No, yeah, so they're not free floating in the abdomen.
Great.
There's a ligament on each ovary that ties them to the pelvic side wall. They are not attached to the tube, which is a common
That's what the diagrams
misconception.
all look like.
Yeah.
It's like it's holding it.
Yeah, no, they're not attached.
The
but
finger-like
it is-
projections are a bit like
Absolutely gripping on.
They're free to float wherever they want, the finger-like projections. But no, the ovary is attached to the pelvic side wall and also to the uterus as well.
but it's not like solid, so
No.
it can move.
It's got a bit of flexibility.
Yeah, definitely.
Then a very frequently asked question, why do I feel so rough in the second half of my cycle?
Progesterone.
One word answer. There we go.
So high levels of progesterone make you feel bloated, your boobs
Constipated.
feel sore, you've got slower gut transit, so you feel constipated.
Tired.
So yeah, that's why
Moody.
it is. It's progesterone.
Meh.
Yeah.
Episode 7, Ovary Overload, Navigating PCOS.
Yeah, so we kind of like this episode because I think there's a lot of things around PCOS that people, loads of myths.
So many
Yeah.
myths.
And I think it was to kind of get good knowledge out that these are little kind of unruptured eggs, unruptured follicles that are in your ovaries, and they're not actually cysts that are abnormalities. They shouldn't cause pain in a sense. They can cause problems with fertility, ovulation. You can have hyperandrogenism, so that means that you've got kind of a male pattern hair growth. You can have acne. But what you should do with PCOS is treat the symptoms. So if you want to get pregnant, then we can think about how you could get pregnant. If you would like to treat the hair on your face, then we need to think about how we could treat the hair on your face. We did discuss, and we know it's easier said than done, but being a healthy BMI makes...
It can make a huge difference.
Makes a huge
in PCOS.
difference.
Yeah.
And it can also kind of just regulate your periods just by being a healthy BMI.
And that's a really key thing. You want to be having at least 4 periods a year.
Yes.
Or no periods because you've got some hormone treatment that's stopping you from having
But if
periods.
you're not on
If you're not on hormones, you should have at least 4 periods a year. Yeah.
And this is because you stay in the first part of your cycle. So estrogen is bombarding that endometrium, estrogen, which can just make it get thicker and thicker and thicker, which can then go to a hyperplasia, an atypical hyperplasia, and an endometrial
Precancerous
cancer.
changes, yeah.
So we don't want that to happen. So we need you to have a period at least 4 times a year if you're not protecting the lining of your womb with some kind of contraception.
Yeah. Got it? So a myth from this was PCOS is caused by being overweight.
No.
It's not caused by being overweight. People with PCOS often struggle to lose weight, and having excess weight can make the symptoms of PCOS worse. But it's not caused by being overweight.
No.
And then our FAQ, does PCOS mean I'm infertile and will never have kids?
No.
Good.
So there are treatments that we can help you have a period and then have an ovulation, because the problem is you're in this first part of the cycle, you never have your ovulation and move to the second part of your cycle, or you just have an ovulation whenever.
It's hard to know when you ovulate.
sporadically.
You can't time it. Yeah.
Yeah. So from that respect, we can advise and give treatment to allow you to ovulate, basically.
Nice.
And fertility treatment for people with PCOS works really, really well. So it's something that helps you to ovulate, and then if you know when you're ovulating, you can have sex, and usually that is really effective for people with PCOS, which is hopeful.
The next episode, 8, was miscarriage matters.
Yeah, so this was a really important episode because lots of women and partners go through miscarriage, but a lot of the times don't feel comfortable to talk about it. So we really wanted to kind of break the stigma and give some useful, accurate information about it. So
I think it's one of those things that, like, genuinely, when you start speaking to people, like, so many people have had miscarriages. Like, pretty much everybody I can think of in my social circle has had a miscarriage or would know somebody who's had a miscarriage.
Yeah,
like,
it's really
it's just so common, and people actually don't talk about it.
Yeah.
So it's 25% of early pregnancies, isn't it, that end in miscarriage? So that's 1 in 4. You know, it's a lot more common than you probably expect it to be.
Yeah.
And a lot of people don't feel comfortable to talk about it because it's not talked about. So break into... You don't have to talk about it if you don't want to, but you should feel comfortable to if that is what you want to do.
Yeah, and we wanted to kind of give knowledge about about how you can go about treatment of a miscarriage. So if you have medical management or surgical management, or if you pass the pregnancy at home and have conservative management, what treatments are available, what access to care is available.
And one of the key messages really was that it's not your fault, which like most people think that they did something to cause their miscarriage, and you didn't.
Just not true.
No.
So sort of following that, our best myth was that certain foods or activities increase your chances of miscarrying. So there were things like flying, like cheese, like sushi.
Yeah, I think people get really obsessed with these kind of things.
Yeah.
And realistically, miscarriages happen on the whole because of a chromosomal abnormality with the pregnancy that's developing. And it was never going to be able to develop into a pregnancy that you would carry to term and have a baby that you can take home with, unfortunately. And the chances of this happening really increase with the woman's age, which is rubbish, but it's a complete and utter fact and has been proven time and time again. So unfortunately, miscarriages happen more and more when you get older, and it's just an age-related rather than anything else-related situation, because more of the eggs that you produce and more of the embryos that are made will have the wrong number of chromosomes to start off with.
There are certain foods you should avoid, but they won't cause your miscarriage. So if you are pregnant, there is a list of foods that you should avoid. It's on the NHS website. That's because they might cause infections that could cause problems with the pregnancy, but generally you eating sushi by accident is not going to cause your miscarriage.
Yeah, great.
Frequently asked question, if I have one miscarriage, will I be guaranteed to have more?
No. So if you have one miscarriage, you're much more chance to have a pregnancy that's an ongoing pregnancy that leads to a live birth in your next time that you become pregnant. Even after 3 miscarriages, if you've had live births before, you are much more likely to have an ongoing pregnancy with a live birth than you are to have another miscarriage. So it's kind of, there is a really good calculator on the Tommy's website that I think actually gives people hope rather than kind of cause people more distress, because you are much more likely to have an ongoing pregnancy than you are another miscarriage. And I think people get obviously worried, upset about this, and you should definitely seek medical attention and speak to someone about it. But having a look at that, I think, can give you a bit more like, oh, actually, I do fall into that camp that should be more likely to be useful. Pregnancy.
Amazing. So then, on to episode number 9, fibroids uncovered, from diagnosis to management.
So this is a whole episode about fibroids, which are Lorna's specialty. So fibroids, there are non-cancerous growths of the uterine muscles, so the muscle layer of the womb. They can be huge, they can be small. Most women will have some at certain points, and by age 50, the majority of women will have had some sort of fibroid change or some fibroids in their wombs. They cause usually heavy periods. They can cause pain, but usually it's pressure symptoms if they're very, very big and they're pressing on your bowel or your bladder or the structures in your abdomen. Treatment-wise, you can give hormone treatments, or you can try and remove them. And removing them really depends on how big they are and where they are in the womb. So you might be able to remove them with a camera, which we have an episode about. Called
we'll get to that one.
Or you might need to have surgery through your tummy, either keyhole or open, to remove them.
Unfortunately, often they come back.
They can come back.
If you're prone and you've had them removed, you're still likely to have them again. So if you're having them removed to undergo, say, fertility treatment, then you should have them removed and have your fertility treatment in a timely manner before they potentially come back.
From what I can recall, this was a crazy one for myths. We had a lot of myths.
There was.
One of our main crazy ones was fibroids are a build-up of toxic waste in the body.
Imagine.
Not true. No, they'll just grow no matter how pure everything is that you put into your body. They will just grow.
You have a good diet, guys. Imagine.
There was another one, wasn't there, about it being toxic masculine energy or something?
Yeah, toxic masculine
you're just not
energy.
feminine.
You're too masculine.
Yeah, it was a bit
Not
crazy,
true.
that one.
No.
And then our FAQ, how will the doctor remove my fibroids? Which we sort of touched
we
on.
covered
So
different ways depending on how big.
Yeah,
and
sometimes you can
location.
do it laparoscopically through a keyhole surgery on your tummy. Sometimes you need a laparotomy, so a big scar on your tummy, either across the bottom like a cesarean section or up and down from your tummy button, depending on how big they are and where they are. And sometimes we can remove them, as we said, hysteroscopically, so a camera through your vagina, cervix, into your womb, and remove the fibroid that way.
She's jumping ahead some more episodes.
So, well, same time. Our next one, I think this is one of my favourite ones.
Yeah.
Endometriosis nutrition with Christy, our first guest.
It was. It
So
was like a
good.
big thing. And also, it was so early in the morning.
Yeah.
Oh,
did we
Australian
start?
time zones.
Didn't we start at 7?
Yeah,
We were recording
I had to
it
be
at
up
7.
at like 6.
You didn't have breakfast that day, did you?
No, never do.
Yeah. I think we'd all come with no breakfast and coffee, and we told Christy, and she was like,
The
guys.
nutritionist.
The first
Guys.
issue.
yeah, it
this
was,
is where we're all going wrong.
She was our first guest, so she was virtual. It was really good. So she's a nutritionist, but has a specialist interest in endometriosis
Yeah.
nutrition. She has a program called Beat the Endo Belly, which you can have a look at. We covered a lot of things. I think we wanted to really get to grips with what diet is recommended for people with endometriosis.
Only because I've seen it blanket policy. Loads of people are like, have the FODMAP diet. And we were like, FODMAP. And Christy
What is
put
that?
us in
Yeah.
our little place and was just like, you can have a FODMAP diet, but it's a short-term plan.
Yeah.
Not a for the rest of your life
No.
Live
plan.
on it.
So that's the FODMAP. You're meant to avoid FODMAP things, aren't you? So they're full of like things that are difficult to digest. So you have a low FODMAP diet. But we thought you were on that forever.
Yeah.
And she said, no, it's not. It's for a short time, and then you reintroduce. And there's different types of diets that are useful for people with IBS and endometriosis.
Yeah, I think we had a really nice discussion about the lack of knowledge that we had around this.
Yeah.
And I feel like we could talk about hormones and we could talk about surgical endo treatments till, well, forever. But and how hormones affect and all this kind of stuff. But when it came to like diet and that kind of stuff, I just felt like we were like, and what do you think?
Yeah.
And
It was an education.
Yeah,
it was
for
an
everybody.
education. I
Yeah.
thought she was great. It was a nice introduction to having a guest. And yeah.
And eat the rainbow.
That was her big bit.
Take
wasn't
home
it?
message, yeah.
Yeah.
And our best myth there was probably that certain food groups, namely cheese, everybody loves to blame cheese, cause endometriosis.
Yeah, they shouldn't.
No, not true.
They shouldn't
Don't
blame
blame
cheese.
cheese.
Eating
Don't blame
cheese.
I feel like since this episode, we've
Well,
learned how good
yeah,
cheese is
maybe
for
dot,
lots
dot,
of
dot,
different
let's-
things.
I've
Yeah.
actually had like chunks of cheese from the fridge and been like, it's okay because the dentist said that I should be eating cheese.
And that's a spoiler.
So,
But yeah, not
cheese
true.
does not cause endometriosis.
And the frequently asked question was, what's the best diet for endo?
So
Yeah.
there's different diets, yeah. Then that's what she touched on, and it'd be too difficult to really summarise it into just one sentence.
Yeah.
But it's not just the low FODMAP diet. There are other alternatives, and have a listen to the episode if you want to learn
Yeah.
more.
Then we're up to number 11, which I feel like Nick is so ready for. Let's go out. A closer look at hysteroscopy.
So this was having a look at hysteroscopies. This is a camera inside the womb, and we can do this with people awake or asleep. And I think there is loads of bad press about people having this awake. I promise I do probably at least 10 of these a week. And on the whole, people are really kind of like, oh, was that it? Yeah. And they're very happy with the experience that they have. I love the fact that we can offer them a procedure that means that they can come in, have the procedure, go to our little recovery room now, have a cup of tea, have a biscuit and get off home. They don't have to have
Free
I know,
biscuit.
we have
Sounds lovely.
a new lounge now, free biscuit.
Elders like sign me up.
Just a cream.
I'll have one.
And I just think I think we need to be careful. Yes, it's not for everybody, but a lot of people would be totally happy to have this awake. We can do this asleep as well, and we can do surgeries through a hysteroscopy. So what we can do is remove polyps or fibroids that are in the lining of the womb. We can also remove, some people will have septums, some people will have adhesions. So there's lots of things that we can do hysteroscopically, so a camera inside the womb.
Amazing.
Big myth. Can it diagnose endometriosis?
No, so endometriosis is the lining of the womb outside of the womb, and we are looking inside the womb with a camera. So,
So
no.
it's good
Yeah.
for some things, but some things.
Well,
doesn't
it's just
do.
not looking at that.
It's not looking
And
in the right place.
A lot of times when people say, "Oh, could you check the cyst on my ovary?" or that kind of thing, I'm like, "Babe, if I'm checking that cyst on your ovary, I'm in the
so
wrong
wrong.
place." So you need to keep,
Listen to Back to Basics, guys.
Yeah.
And then you'll get it.
yeah, you're within the walls of the womb, not outside of the womb for definite.
And I think you've touched on it, but the most frequently asked question was definitely, what pain relief or anaesthetic will people be getting when you do this to
Yeah,
them?
so they have pain relief before they come into the room if you're doing this awake, and then you put local anaesthetic into the cervix, and we also have gas and air for those that want it as well. So they have lots of different options, and we always say, look, you're in control, you're awake. You tell us if it's an issue, we book you to have it done asleep.
Yeah, and you can have a
Amazing.
general anaesthetic if you want one to start with.
Next one, number 12, infertility insights, what you need to know.
Yeah, this led on nicely from our how to get pregnant. So if you're not getting pregnant and infertility might be something that you have, then we wanted to cover what you needed to know about that. So it's quite common, isn't it? 1 in 7 couples will have infertility. It's either male or female factor or unexplained. And it's a third of causes are from the man, a third from the woman, and a third completely unexplained.
Loads of them are just crossed over, to be honest. So we see a lot of people that there's a mixed picture, like the sperm is not that great and the lady's got PCOS, or there's a problem with the tubes and there's a problem with ejaculation. There's can be lots of different things that go on.
It was a really good episode, I think, really informative, because you went through all of what can cause infertility and then what treatment you might need, and then a real good walk through IVF treatment, which I remember was really thorough. Yeah, which I think would be useful for people who might need it.
Yeah, the investigations that you have and what not to have as somebody who's sat at home. I think we discussed that quite a bit as well.
The tests.
Yeah, because
Don't
I
order a
think,
test off Instagram.
yeah.
Go to your
Or
GP
TikTok.
and go to a fertility clinic. Yeah.
I just think it's so difficult if you're getting a test and you don't know how to interpret the results.
And not
then
support them.
actually, it's really not fair to then go and see your GP, who also potentially doesn't know how to interpret these results in the context that it's come in, because if it's not something that they work in all the time, then they shouldn't be put in that position. So if you're going to have a test privately, make sure that you've got a consultation as well.
Yeah.
I think that is a good plan.
Yeah. And I say best myth, probably the worst myth. If you just relax, you won't be infertile anymore.
Perfect, yeah.
It's really helpful to people out
Yeah.
there trying to get pregnant. Just relax.
Try not to think about it.
Yeah, just don't think.
Yeah,
You'll be
don't
fine.
think about it.
Not
Yeah.
true.
No.
Frequently asked question, if any, what supplements can I take?
Yeah, I think this one was the one where we didn't talk about folic acid. So
No.
we got
Yeah, we got in trouble.
we
You
got
should
back
take
from-
folic acid if you're trying to get
folic acid
pregnant.
if you're trying to get pregnant.
Bottom line.
It's the only one that's been proven to help with anything, and it massively decreases the chance of a neural tube defect in the baby. You should totally be on folic acid.
Amazing. Number 13 was ectopic pregnancies, lost in transit.
I really love the
that.
title.
That's a really good
Great
title. So we might have to do a
titles.
poll and everyone say what their favourite title
Oh,
is.
yeah. That's a good idea. So yeah, an ectopic pregnancy is a pregnancy that is implanted outside of the womb, so it's not where it should be. It is most commonly in the tube, but it can be in other parts. It can be in the cervix, it can be in the ovary, it can be where the tube joins the womb. The key thing here is that they will never grow into healthy pregnancies. They do need treatment. They might go away on their own, but you need to be under the care of a medical professional. Most people need either medical or surgical treatment, and that treatment is not a termination. That is you treating something that might grow and can be a life-threatening emergency.
Yeah, it's never going to be something that there was a study in America saying that we could like pick this pregnancy up and put it in the right place.
No.
You can totally not do that.
Doesn't work.
So, big myth, you can't get pregnant again after an ectopic pregnancy.
Yeah, not true. So, not true.
False.
False. You have potentially had a tube removed, but you might not have had a tube removed, because there are 3 different treatments for ectopic pregnancy. One is conservative, which is only appropriate for some people in certain situations, whereby you would have kind of blood tests and sometimes ultrasound scans to make sure that the pregnancy has kind of gone itself. That's usually if a pregnancy was already failing. Then sometimes people have methotrexate, which is an injection, which stops the pregnancy tissue from dividing, and then you wouldn't need surgery, hopefully. Again, only appropriate for certain people. We go into this in much more depth.
Yeah, we
add.
do.
And then the other is to remove the fallopian tube, which is the tube where the egg is, when it comes from the ovary, how it's transported into the womb. That is removed in its entirety with the pregnancy in it. So it would decrease your chance of getting pregnant because you're taking a tube away, but it wouldn't completely negate your chance of pregnancy because you've got a tube at the other side. And also it can be wafted from
The other
one
side.
ovary to the other tube.
Amazing.
So it doesn't decrease it by 50%.
So I feel like you've answered our FAQ,
Yeah,
which
that
was,
was the next one.
does it? So that's ideal.
Oh, well,
Should we
thank
go on
you.
to the next episode?
It makes sense. You would think it would reduce your fertility by half, but it doesn't.
No.
It reduces your fertility slightly, but not by half.
No.
So you're still more
Great.
likely to get pregnant and have a normal pregnancy next time. Yeah.
So, another scoping it out, episode 14, was scoping it out, a closer look at laparoscopy.
Yeah, so we did this one because loads of people have laparoscopies, especially to look for endometriosis, or if they've got an ovarian cyst, or any other pathologies on the outside of the womb that include their tubes or their ovaries. And we put a camera inside the tummy button and usually put a couple of other ports, either at the left or the right side or suprapubically, just above where your pubic bone is.
Suprapubically.
Just above where the
Love that.
bony bit at
Not
the front.
super pubically.
Not super,
I
sorry.
heard super pubic, and I was like, woo!
It should be that would be great.
A good superhero.
Just above that
Supra.
bony bit of your pelvis at the front.
Okay.
Okay,
Suprapubically.
that's exciting.
Sorry. And we have a camera inside, and then we can put instruments through these other ports to be able to manipulate things, have a look behind things, look for endometriosis, take down adhesions, take away ovarian cysts. There's lots of things that can be done through a laparoscopy.
So the best myth here was that laparoscopy is only used for diagnosis. Treatment would be a separate operation.
So this used to actually be a thing. So
Okay.
we used to just do a diagnostic lab, wake you up and be like, you've got endometriosis. Do you want to do anything about it? Or like, you've got some adhesions. Do you want to do anything about it? And that is genuinely what we used to do.
That's all you could do. It
Yeah.
was literally, you would look through the belly button with like a little telescope. You'd look inside and be like, okay,
I love the
that's
idea
what
that
that
you're
is.
up at a belly button just...
But you wouldn't be able to operate it. You would just be able to
It
look.
does
Yeah.
feel like
Yeah.
such a shame, doesn't it?
Yeah.
That you couldn't just carry on.
Two for
Yeah,
one.
but now
So
Why
that's different now.
the
Yeah.
consent form is massive and covers like, if we see this, we will do this. If we see this, we will do this. If we do, if we see this, we will
Yeah.
do this. And that's because obviously we don't want to have to wake people up. We don't want them to have to wait for a long time. We don't have to go with the risks for another operation. So, for example, if we think that we're going to go in and you've got fluid in one of your fallopian tubes, so we're going to remove that fallopian tube, and we get inside and we're like, oh, actually, there ain't any fluid in the fallopian tube. They've got a cyst that's hanging off their ovary. We could remove that cyst from them, leave the fallopian tube, and kind of do what's necessary rather than kind of come out and be like, no, you've not got that problem that you thought you had, but you have got another problem.
Yeah.
So we kind of try and deal with everything at the same time.
And also, if they have pain and they've consented beforehand, you could put a myarina coil in as a treatment.
If it's
Yeah.
on your
During
consent form,
If it's
then
your consent
you can get
form
it.
and
Yeah.
you've had like a discussion about it, then yes.
And
We can't do something that you've not consented to.
Yeah.
a frequently asked question was, will my laparoscopy affect fertility?
No, it shouldn't do. So
Depends where you're operating, doesn't it? Like if you're operating on someone's ovary, then it will potentially reduce the fertility. But if that was going to happen, the person doing the surgery would have talked to you about that beforehand. A diagnostic laparoscopy should not affect your fertility.
no, but there are big considerations. You're totally right. So if somebody has got ovarian cysts, then we would discuss with them about potential fertility in the future. Because if we're removing cysts, especially if we're removing cysts in their entirety, then we're going to destroy good ovarian tissue as well, which will decrease your fertility potential. So all these need to have proper conversations
Yeah.
around, basically.
And then our next episode, number 15, was ovarian cancer, facts, myths, and future frontiers, which was a lot to get into one episode.
Yeah, it was a big
actually is.
episode. So we wanted to cover ovarian cancer because it is not the most common cancer, but it's often a cancer that you don't get a diagnosis until later on, which means that the treatment can be, quite invasive surgery, and the prognosis isn't always great. So we wanted to kind of raise some awareness and give some accurate information about it.
Yeah.
So we covered different types of ovarian cancer, the symptoms that you might get, what to look out for, and what to do if you thought you might have any of those symptoms.
Yeah, I think it was kind of a twofold thing, wasn't it? So to tell people what symptoms could be related to ovarian cancer, but actually to tell people that most of these symptoms will not be related to ovarian cancer.
Yeah.
And also to hammer it home that there really isn't a very good screening test for an ovarian cancer. A screening test has got to be something that shows us a condition before it gets to something bad.
Yeah.
So like
your
a smear.
Like
Yeah.
Jinx.
But
Which we'll come on to.
yeah, but for ovarian cancer, we haven't got like a pre-lesion to look for.
Yeah.
So I think it's frustrating for a lot of people, especially if they have it in their family, that they want to be able to know what's
Ahead
going to
of time,
happen.
yeah.
And actually, we just don't have that.
No. That leads us on nicely to the myth, which was a smear test can detect ovarian cancer.
No, a smear test, cervical smear test is to detect precancerous changes for cervical cancer, not for ovarian.
Not for ovarian cancer.
And we've touched on it there, but does ovarian cancer run in families?
It can do.
There we go.
So if you have BRCA mutations, they can be related to ovarian cancers just like they're related to breast cancers. And there are other kind of conditions that can run in families that would cause an increase with ovarian cancers. So for those people, usually they would kind of have an insight into that because they would know that they're at risk and they will have seen a geneticist. It would be good to have a geneticist on, I think, at some point.
That would be good, yeah.
Let's think that.
Watch this space.
Put it on the to-do list. So it can run in families.
Okay.
Next one, episode 16, we're getting there. We've got contraception choices even. Let's pill the tea.
This is my favourite
We
title,
were
I think.
on it with
Yeah.
the title.
All the
Alison, you can't
pregnancy
keep
ins
moving
and
on with
outs.
that.
I
You've
love
said it like
this
3
one.
times now.
They're all so good.
Oh no, my favourite's coming up.
Well, this one, was all about different types of contraception. So we covered things from the pill, patches, vaginal rings, coils, implants, all sorts of things.
This was a massive episode.
It was humongous.
But I
lot to
actually really
cover.
enjoyed it because I think it really went into all of the contraceptives.
Oh, defo.
But you need to have like a long car journey or a big run. And
Yeah.
really take it in.
Yeah.
guys.
Take the information in, and by the end of it, you'll know what's for you.
Yeah,
Absolutely.
Or listen in
Yeah.
segments if you want to break it up.
Yeah. Okay. So lots of different contraceptions. Some are suitable for some are not suitable for others. And we discussed about that you can stop your periods, and we are great advocates
benefit
in
of
stopping
mums.
periods. And when people have periods, for example, on the combined oral contraceptive pill, it's not a period, it's a withdrawal bleed. And I think they are falsely reassuring to some people. So we discussed at length about the pros and cons to having periods, or the cons and cons to having periods.
Depends how you look at
There's
it.
no benefit to having periods, in our opinions.
And a really common myth in this one was that if you stay on the pill for too long, it will affect your fertility.
No, not true. And another thing that there's a myth that we always see is that, people need to have a detox after hormones. You do not need to. If you're on a pill that is working for you and you're not having a period, you don't need to detox.
You're
Just
Friday.
carry it
Stick
on.
with it.
Yeah.
And then a frequently asked question, which I feel we've seen a lot of, is do I need to take a break and have a bleed on the pill?
No, you don't need to.
Your body at some points might tell you that you need to have a bleed. So, for example, if you're on the combined oral contraceptive pill and you're taking it back to back, so that's the one that a lot of people will take for 21 days, then have 7 days off and have a bleed. You don't need to do that. So you take it for 21 days and then another 21 days,
Start the
then
next
another
back,
21
yeah.
days.
Yeah.
Then sometimes some people will have a bleed. If you have a bleed, a breakthrough bleed, then stop it for 7 days and then restart it again. So you don't have to have a period on the combined oral contraceptive.
Majorly beneficial.
Yeah, I feel like that's such a win. Episode 17, the cervix is in, why screening saves lives.
Yeah.
Such a good episode.
I love this
We
episode.
had so much fun.
So we covered what the cervix is. It's the fibrous structure at the top of the vagina and the entrance to the womb. Cervical screening is the best screening test that there is out there.
We love
it. There was a big change after we released this episode. Literally like the next day.
Genuinely.
After we recorded
After we
it, not
recorded
released
it.
it, we saw that there was a big change in that women in the UK, well, in England and Wales, don't have to have a screen every 3 years. It increased
every
to
5
5
years
years.
for
Up with
everybody.
Scotland.
So if
yeah.
you're from 25 to 64, you have a screen every 5 years, and it helps to detect precancerous changes on your cervix, which can be treated to prevent you getting cervical cancer. So it's an
This is an
amazing,
amazing
screening
screening
program.
I can't believe the people that made that policy didn't think to tell us before we made the episode.
They should have
rude.
called in, shouldn't they?
You could have taken
Giving us a
picture
heads
of
up.
us.
We did do some videos to be like, guys,
Here's
we
the
need to
update,
tell
here's the
you
update.
every 5 years.
And we promoted the cervical screening
Yeah,
bus
the
in
Living
Liverpool,
Well
which was
bus.
brilliant.
Yeah.
They had a
was
fun
really
name for the
good.
bus, didn't they?
Living
Living
Well
Well
bus.
No, but it was like cervix in the city or
Oh,
something.
yes.
Sex and the
I was
City,
like, oh no, I've said
it.
this and I can't remember.
I like it.
So a myth from this, if you have HPV, your partner is definitely cheating on you.
No.
Not true. No.
A myth.
No.
So HPV is the virus that causes most of cervical cancer, and that's what we're looking for when we're doing the smear. So they check it to see if you're HPV positive or negative at the beginning, but people can have it at various different times of their life and kind of clear it and then have it and clear it and have it, but it doesn't mean that your partner's cheating on you.
Great. The question that we saw a lot was, if my smear test is normal the first time I get it, Do I really need to go back?
Yes, you do, because you might then get HPV infection, and then that can cause changes that can lead to cervical cancer. So if it's normal once, great, good for you, but do go back in 5 years' time.
Great.
And also every 5 years. I mean,
It's
come
not
on.
a big deal.
It's not too much, is it?
You've got a oh, we also didn't we do a smear? We did a smear like video to show people what happens in a smear.
Yes, we
Yeah.
have.
Yeah, so
a
I'm just kind of
run-through.
like, it's very quick and easy,
It
guys.
is,
Come
yeah.
on, have your smears.
Have your smears. Next one, we've got adenomyosis. I don't know meiosis. I like that.
Catchy title. So we wanted to cover this because it's another condition that can cause heavy painful periods. It's the lesser known condition to endometriosis. So adenomyosis is where the endometrium, the lining of the womb, grows abnormally into the muscle layer of the womb, and that is where it's contained. It doesn't grow outside of the womb. It causes heavy painful periods, chronic pelvic pain. It can be associated with reduced fertility. And the key thing with this is it's hard to diagnose. So you can now diagnose adenomyosis on ultrasound or MRI scan, but not everyone is suitable to have one, not everyone will have one. The best way to diagnose it is after you've had your womb removed, which is obviously not ideal for a lot of women.
Definitely
and
not ideal.
treatment-wise, the
intense.
only cure is hysterectomy,
Yeah.
but you can manage your symptoms with hormone treatments as well.
Amazing. So our big myth here was that it only affects older women who've already had children.
Yeah, not true.
More common though.
Yeah, it's more common.
Yeah.
The older you get, the more likely you're to have adenomyosis, but some younger women do have it as well.
Yeah.
So yeah, myth.
And a question is, can adenomyosis spread like endometriosis?
So it's specifically in the muscle layer of the womb. That's what adenomyosis is. So it can't spread outside of the womb. You might also have endometriosis. It's really common to have both conditions.
What did we call them? Evil twin
Twins.
Yeah.
Something like that.
Evil second cousins. Something like that.
And then that led really nicely into a big guest, our interview with Nagaman Shetty, all things women's health.
Yeah, so we did chat all things women's health. There wasn't kind of a like, obviously we discussed about her journey and her journey to diagnosis with adenomyosis and the problems that's caused in her life with heavy painful periods,
Yeah.
the treatments that she found to help, the treatments that she did not find
She's a
to
big fan of
help.
the depot, wasn't
Yeah,
she?
she loved the
was,
depot
yeah.
for a long time. She didn't like having the coil fitted, but she was very open about saying that just because it's not for her, it doesn't mean it's not for anybody else,
Yeah.
which I like. And she also discussed about like navigating her career while dealing with heavy painful periods,
Yeah.
which I think is great for people to hear, and to hear it from somebody who said, look, you do need to tell people because then you're honest and you're not trying to like hide things.
Yeah.
You're having like
Yeah.
an open, honest conversation, which I
It
think is a
was
good
great
thing.
to hear her experiences.
Yeah, it was brilliant.
We did talk about gaps in menstrual education as well with her, didn't
Yeah,
we?
we touched on that there.
Which was kind
And
of
how to advocate for yourself. I think that was a big
Yeah.
message from her, like having had these problems, what she wanted to get out to other women to help them get the help they need from their GP and the NHS. Yeah.
Brilliant.
Yeah.
Episode 20 was Beyond PMS, Demystifying PMDD. All the letters.
so yeah.
Go on,
PMDD.
give us a
That
quick
is
run-through.
a lot of letters.
Yeah,
So-
maybe not our finest title.
We could have done better there. Never mind. There's always next season. So PMDD is it's a premenstrual dysphoric disorder. It's not, the key message here is it's not just a severe form of PMS. So we all know PMS is when you get quite moody, tired, the bit before your
Yeah,
period.
we know her well.
Yeah, we know
her well.
PMS. Well, PMDD is a severe reaction of the brain to the drop in hormones just before your period, not just before, but during the second part of your cycle. And this can lead to really horrible impact on people's mental health. It can cause really bad depression. It can make you suicidal. But the key thing is that it just happens for 2 weeks of your cycle.
Yeah.
So if you can keep a cycle diary and you can see that every 4 weeks you're feeling like this, but then you have your period, you feel better for a couple of weeks, and then it starts again, that's a really key sign that it's linked to your hormones.
It just can be massively debilitating, because if you think that you've got 2 weeks where your body is not happy with your hormones
Yeah.
and you are genuinely like a different person in that 2 weeks, like you can't control your emotions, you can be really like a different person with your partner, different person with your children, you're depressed, you're anxious, you're suicidal for 2 weeks, then you get your period, and in a sense that's a relief to get your period, but then you've got a period,
Yeah.
so you're like,
You've
then
got to
you're
deal with that
bleeding,
for a
you've
week.
got cramps,
And then it
you've
happens
got,
all
and then you've
over
got a
again.
week where you might feel okay, and then you back to the other. Like
It
a
just
week
must take
before.
out so much of people's lives.
Yeah, it's not ideal at all. But we did discuss that there is more kind of notice on this now, because a few celebs have come out and said that they do suffer with this, and they've had different treatments that have helped, which I think anybody who talks about these kind of things means that other people can be like, oh, I might have that, and then they know to be able to kind of keep a little diary and go see somebody and say, what can we do about this?
Yeah, and I think that leads in nicely to the myth that we had, which was there's no point getting a diagnosis because no one can do anything about it.
Imagine.
There's lots that can be done about it. There's
What
lots
a
of different
concept.
treatments, and also just knowing what is causing your symptoms can be really helpful. Just
Yeah.
giving it a name. But yeah, there's medical treatments, there's CBT, there's antidepressants, there's all sorts that can be helpful. So get a diagnosis.
Yeah, by stopping you having a cycle and making your hormones kind of level, a lot of people will find that kind of very helpful. Some people end up actually having a surgical menopause where they have their ovaries removed to treat the condition, but that would be kind of worst case scenario. But there are lots of things that we can do to manipulate your hormones to kind of put you on a more even keel, so that you're not having these massive fluctuations that your body just does not like.
And a question is PMDD cured by a hysterectomy?
No, because you would still have your ovaries producing all of the hormones, so no. It would be cured, well, it wouldn't be cured, but you wouldn't have these hormonal fluctuations if you didn't have your ovaries, but hysterectomy is just removal of your womb, and so therefore you would still have all the hormones. So no.
Okay, and then that episode led into episode 21, From Surviving to Thriving, a PMDD Story. A much better title.
Yeah.
That's really good.
This was just a nice little chat. So we kind of discussed with Keisha about like how she was diagnosed with PMDD, and it was just such an interesting story that she like fell onto it really.
It was like a doom
onto it,
scroll when she found it.
Yeah, she basically diagnosed herself didn't she,
Yeah.
after reading online and putting her symptoms into what she found. But it was really interesting
And
to
it was
hear
great from her
side.
because she could tell us how well she could be controlled on hormones.
Yeah.
She said trying to get pregnant was a mission because she didn't want to come off the hormonal treatments, because she knew how bad she would feel off the hormonal treatments. But while she's on the treatments, she feels really great, which is fantastic, obviously.
Yeah.
And then 22 was More Than Cramps, the truth about chronic pelvic pain.
So this is pain in the pelvic area for more than 6 months, and it's independent of periods, pregnancy and intercourse, and it can be caused by loads of different things. And I think that's what we touched on basically, that it's really difficult to give you kind of a one-size-fits-all diagnosis. Just because you've got pelvic pain doesn't mean that you automatically have endometriosis. You could have lots of different conditions, and sometimes people have more than one condition, and what we should try and do is treat the symptoms first of all, and kind of try and make life better so that you can live your best life.
Yeah. I feel like that's your catchphrase. One of many.
One of many.
And the myth here was that if scans and tests are normal, then nothing can actually be wrong.
Yeah,
No,
that's so untrue.
It's like
Yeah.
a diagnosis of exclusion, isn't it, as
Yeah.
well? Like, you might have chronic pelvic pain but have no condition that we can see causing it,
Yeah.
but you still have the chronic
pain.
pelvic pain. So your test can be normal, but you can still be in pain. Yeah.
And a frequently asked question is chronic pelvic pain more common in older or younger women?
It's probably a bit of a mixture, isn't it?
Yeah.
It's more it's more common than you think. Lots of people do have chronic pelvic pain, and it can be caused by things that are more common in younger women and things that are more common in older women.
Yeah.
So it's probably a bit of a mix.
No, I agree.
It's a tough one, that one.
I agree.
And then episode 23, we are getting there. Paula Radcliffe, pregnancy, periods, and podiums. We're Nick fangirls.
I tried not to fangirl, but
You did a little bit.
I definitely did fangirl. And it was just, do you know what? It were a really good episode.
It was so nice. Yeah.
Because she was just so chatty and open, and
Yeah.
we asked all of the questions that we wanted to ask about her career and running around her career, and we talked about puberty, pregnancy, postpartum, and a bit about menopause as well. The whole journey.
The lifespan.
Yeah, I think it would be great for listeners to listen to that, because I think everybody can get something out
Oh,
of it.
for sure.
And it's the Paula Radcliffe.
Yeah.
I think, and if you're pregnant or trying to get pregnant and running, listen to that episode, because it'll give you lots of reassurance about what you can do when you're pregnant.
Yeah.
Not that you will be as good as Paula Radcliffe.
Well, you never know.
But, she talks about hill running was useful for her in
yeah.
pregnancy and why that's useful. So, I thought it was a really interesting episode.
Yeah,
Agreed,
it was
agreed,
good.
agreed. So the best myth from that was the menstrual cycle makes women too inconsistent to train seriously.
I know, which was just a joke,
Look at
wasn't
Paula.
it? I know. And we did discuss about cycle syncing and that actually it's probably not a good idea because if you cycle sync in a chronically under-exercised population and we're then telling, we're not at all, but some people with these kind of approaches where it's a one-size-fits-everybody are telling you to only do a vigorous kind of exercise in 1 to 2 weeks of that 4-week cycle. When you're already not exercising enough, don't cut out exercise.
Yeah.
You can
listen
still
to your
cycle
body.
throughout your cycle.
I love that catchphrase.
Well, I feel like very much listen to your body and do what feels right for you at the right time of your cycle.
Definitely.
But exercise is really important and really beneficial, whatever age you are.
Definitely.
100%.
Wherever you are in your cycle.
Wherever you are.
And our frequently asked question, which I think Alison touched on there, can I still run when I'm pregnant?
You can. You don't have to, but you can. And if,
Yeah.
if you've been running consistently beforehand and you want to carry on running in pregnancy,
Totally
it's
fine.
safe. But don't just suddenly get up off the couch and run a marathon when you're pregnant because that's not going to be helpful.
The body's going to be confused.
Then episode 24 was Little Patients, Big Questions, Paediatric Gynae 101.
Again, I think this was a really educational episode.
Oh yeah, we learned
I feel
so
like
much.
I'm just
Yeah.
going to put it out
The
there,
whole
but
time
you
I was
guys
like,
were just like, what? What are you doing
Excuse
to
me,
me?
what was that? How does that work? Yeah.
We were just thriving because we're still adolescents.
That's what, yeah.
Adolescent till April.
So we had Dr. Cara Williams, who is a paediatric gynecologist, and she talked us through what her job is and what paediatric gynecology actually involves. So it's actually a lot of really common things.
Yeah.
So we talked about like babies and vaginal discharge. Should that be present? What's normal? What's not? The fact that babies can have a little period after they're born.
That was mind blowing.
And it's all due to the kind of drop in hormones after they're no longer in their mother's body. It was really interesting,
Yeah,
wasn't
we
it?
talked
was
about
great.
normal anatomical differences that
Yeah.
people make abnormal or they kind of pathologize, like they make it kind of like an abnormality
Yeah.
and you shouldn't do that.
Yeah.
And I feel like Cara was hammering it home that actually she spends a lot of her time just kind of telling people that this is normal, this will go away. This
Yeah,
is
a lot of reassurance.
lot of reassurance.
And again, there was the no soap on the vulva message.
Yeah.
No bubble bath.
Oh my gosh.
No soaps down there.
Cara was all about that.
No bath pins.
No.
I know. I was in
No,
trouble
no.
for suggesting that jelly bath thing that I used to always want when I was little.
It was a no.
Yeah, it was a hard no.
Hard no.
So our best myth was that children shouldn't have gynecological issues. If they do, it might be a sign of poor health or poor treatment.
No. And this is a myth. Obviously, there will be the minutiae of people that are seen that will be because of poor health, poor treatment, and their parents or their caregivers are potentially not giving them the best care. But on the whole, it's because this is a normal thing.
Yeah.
And also, it can just be done with kids because, like, kids put their hands in everything and put their hands everywhere
They don't know
and
how
don't
to
wash
wipe,
them.
do they? They don't know what
Yeah.
they're doing down there. There's
No.
poo everywhere,
Yeah.
so they're going to have
So-
problems.
Everywhere.
Classic kids.
And a frequently asked question was, what can I do if I notice my child is struggling with their periods or with going through puberty?
So be honest and open and have a conversation with them, and everybody should be able to do this, and we really advocate for this. Please speak to your children, speak to whoever
talk
you
to you,
yeah,
yeah.
let them talk to you, let them make sure that they understand that you have an open, honest dialogue. And if
Yeah.
you think that they have really heavy periods, please see somebody about it, because we do see people with like really low hemoglobins because they've been bleeding so much because they've got periods all over the shop at the beginning, and it doesn't mean that they're going to have a lifetime of problems, but we can put things in place so that we can help them.
Amazing. And then we're finally on to episode 25, the final one of season 1.
What a mammoth season.
It was huge. We really went for it. And that was menstrual education.
Yeah.
So
Such a
we
big
had
one.
another guest on. We loved the guests towards the
really
end of the
did.
season, didn't we? So this was Miss Nikki Jones, who is a good friend of mine and is an English teacher and a deputy head of her school. And we got her on because we wanted to hear all about menstrual education in schools. And she actually enlightened us. I think at the end I felt more optimistic.
Yeah,
So
definitely.
we did learn that actually there's been big changes in the curriculum and now boys and girls are generally taught together, but we did talk through some of the gaps still, so there's not a lot of information there about things like infertility, endometriosis, menopause.
When things go wrong,
When things go
basically.
wrong, yeah. But also, I think it really highlighted how difficult it is for teachers to give that education, because a lot of the time they don't have any special training. They're just sort of like thrust into, you must do this, and they have to find a way of doing it. So we have to be, yeah.
And then a myth from this was, if someone's on the pill, they must be sexually active. So that's if a child at the school is on a pill, they must be sexually active.
Yeah, not true, because as we know from our contraception episode, there's lots of benefits to the pill, such as stopping or making your periods lighter, less painful.
Yeah, which is helpful when you go to school. It's helpful always.
Always helpful.
Frequently asked question here was, as a parent or carer, how can they make it as unawkward as possible? They don't want to embarrass their child while trying to talk about any of these things.
I think starting right from the beginning, so when your child is small, always being open and honest. If you're having a period, then you tell them what you're doing, that you're not going to bleed to death, that you've got a period, it's for a short time of the month, this is what happens, this is normal. If you normalise things from the beginning, then if they've grown up with it, it will always be normal to them. So I think just kind of not hitting things out of the blue. And if you don't feel comfortable, there's loads of resources online or books that you can get, because some people just genuinely won't.
It might give you the language to talk about it if you're not
so you
too
could look
comfortable to do
through
that.
something together to have a chat about it.
I think that rounds it off. What a season,
Amazing.
guys. We did so good. And
huge.
25 episodes.
Yeah.
So each thing we've touched on today, we've got a full episode on, which you're welcome to go back, have a little look, pick and choose what you fancy looking into more.
A
We'll let you
year-long
guys talk
season.
Yeah.
A year-long
Whistle
season.
stop
We're not going to do that again.
No, we're mixing it up.
Yeah,
We're
we'll
gonna
mix
do
it up. And
Shorter
we're going to do
seasons.
shorter seasons, yeah.
So yeah.
Perfect.
But now we've got season 2 out.
Yeah.
So if you've got questions that we haven't covered, let us know. Hopefully you're enjoying season 2. And stay tuned for season 3. We're going to keep going.
Yeah, and definitely do let us know if there's anything you want us to cover. I think
Yeah.
we'd like to hear,
We're always looking for new ideas. I mean, we came up with
Absolutely.
one during this episode.
Yeah.
so-
Geneticist, it's in there.
It's on the to-do.
to-do list.
To do.
Brilliant.
Yeah.
So, as usual, just a little disclaimer. Everything we have discussed today are our own opinions. They're not affiliated with where we work and shouldn't be taken as personal medical advice.
Yeah, so if you've enjoyed the episode, if you've learned something new, if you're going to go back and look at another episode, please do leave us a review wherever you get your podcasts.
It may seem like a little thing, but giving us a 5-star review pushes the podcast out to as many people as possible. And we really want to break down barriers, bust myths, and give out really good information.
And we want this podcast and all of these episodes to reach as
Yes.
many people as possible. So if you want to be a part of that ripple effect, then please hit the like button.
And make sure you're following us at Between Two Ovaries on all of our platforms and engaging with our social media content. Thank you.
Bye.